My name is Barry Borlaug, and I'm a professor of medicine and a cardiologist at Mayo Clinic in Rochester, Minnesota, United States. And I'm talking about the HELP PH-HFpEF clinical trial. Well, about half of all people with heart failure have a preserved ejection fraction. And unlike people with heart failure and reduced ejection fraction, where there are multiple proven effective treatments, there's really no conclusively proven medical treatment that helps people with heart failure with preserved ejection fraction. And a substantial proportion of patients with HFpEF have pulmonary hypertension or PH. We call that PH-HFpEF. And these patients have worse hemodynamics, worse exercise capacity, higher risk of hospitalization, and increased risk of death. So they're a sicker subcohort within HFpEF. So we wanted to look for a treatment that might be particularly effective in this subpopulation of patients with HFpEF, given the glaring unmet need of inadequate treatments. Levosimendan is a relatively short-acting intravenous drug. It has a half-life of only 1 hour. So one would think that it couldn't be suitable for chronic use, but it has an active metabolite with very similar vasoactive properties, which lasts for several days. So the idea here was that once weekly infusion of intravenous levosimendan could be used as a treatment for people with PH and HFpEF. So to test this hypothesis, we conducted a randomized double-blind placebo-controlled trial. In the study, patients went to the cardiac catheterization lab where we ensured that they met inclusion criteria of having pulmonary hypertension, a mean PA pressure of 35 or higher, and evidence of high left-sided filling pressures. So they had to have a pulmonary capillary wedge pressure higher than 20. Patients then did an exercise test. And then as long as they met those inclusion criteria, they then received open label intravenous levosimendan for 24 hours, which was administered in an ICU setting in the hospital. The following day, they then had a repeat cardiac catheterization. And we only included people that responded to the levosimendan. We identified responders as those with a 4 millimeter reduction in pulmonary capillary wedge pressure during exercise. The idea being here that if patients didn't have a favorable response to open label drug, we wouldn't want to put them at the risk of receiving an intravenous therapy chronically. So patients that met this criteria of acute response, which was seen in the majority of patients, around 85% of patients, they then went on to phase 2 of the study, which was a randomized double-blind placebo-controlled portion, where patients were randomized to receive either once weekly intravenous infusions of levosimendan or intravenous placebo for 6 weeks. So they received this at their homes, administered by a home nurse, and then they returned for their 6-week follow-up visit where they underwent repeat hemodynamic assessment. The primary endpoint of the trial was the pulmonary capillary wedge pressure during exercise, measured invasively as compared to baseline in levosimendan versus placebo. And then key secondary endpoints looked at other hemodynamic indicators, including pulmonary capillary wedge pressure averaged over all stages, rest and exercise, and submaximal exercise capacity assessed by 6-minute walk distance. The open label administration of intravenous levosimendan led to a reduction in pulmonary capillary wedge pressure, right atrial pressure, and pulmonary artery pressure. This was administered to all of the patients, but that wasn't the main goal of the trial. The main goal was to compare the placebo response versus the levosimendan response with chronic treatment. And again, the primary endpoint was pulmonary capillary wedge pressure during exercise, and as compared to placebo, that was not significantly reduced. However, a secondary endpoint of pulmonary capillary wedge pressure incorporating the data from rest with feet up prior to exercise and exercise, there was a statistically significant reduction in average pulmonary capillary wedge pressure over all of those phases of roughly 4 millimeters of mercury, which was statistically significant as compared to placebo. The other key secondary endpoint of the trial was 6-minute walk distance, and this was improved as compared to placebo by levosimendan by an average of 29.3 meters, which is about a 10% improvement in 6-minute walk distance. Well, we conclude while the trial didn't meet its primary endpoint of exercise pulmonary capillary wedge pressure, we clearly saw signals of a favorable hemodynamic benefit that we would expect to be helpful in these patients. And the secondary endpoint of an improvement in 6-minute walk distance is extremely important because this is a metric which is very meaningful to patients. It's very strongly tied to patient-reported quality of life. And in fact, this is the first drug trial that I'm aware of where a medicine has actually improved 6-minute walk distance in patients with heart failure with preserved ejection fraction. So I think that despite the fact that the primary endpoint wasn't met, the overall signals are favorable hemodynamic effects and exercise effects. And this really serves as a foundation to move forward with the next stage, which will be a larger pivotal clinical trial of levosimendan in patients with heart failure and preserved ejection fraction and pulmonary hypertension. It did. We had COVID-19 hit right around the time when we were finishing up the study, and one patient who had been randomized to the placebo group actually needed to withdraw from the study prior to completion because of COVID. The study has an open label extension period, which is still underway right now, and we've had to change the study visits for COVID. Most of those visits are now done through the phone or through video rather than face-to-face. So there have been some challenges posed by COVID, but fortunately we were able to complete all of the enrollment prior to this hitting.